Hello students. Welcome to part 2 of the chapter Concepts of Care for Patients with Hematologic Problems. We're going to talk right now about anemia. Previously in part 1, we spoke about sickle cell disease. Right now we are starting with anemia. It's a reduction in the number of RBCs, the amount of hemoglobin, or the hematocrit percentage of packed RBCs per deciliter of blood, and it is a clinical indicator, not a specific disease, and occurs with many health problems. The many causes of anemia include dietary problems, genetic disorders, bone marrow disease, or excessive bleeding. GI bleeding is a common reason for anemia in adults. As we keep going analyzing all the diseases presented in this chapter, we are going to discover the value of good nutrition, how good nutrition and avoiding different types of alcohol, drug, smoking, all of these factors takes place in a good health. Okay, so pay attention to this, and we are going to look and find the relationship between all these diseases and the nutrition or other bad habits. Some are caused by a deficiency in one of the components needed to make fully functional RBCs. Others are caused by decreased RBC production, which could be a problem in the bone marrow, right? Increased RBC destruction could be an autoimmune problem, or chronic RBC loss due to chronic conditions, right? Let's see the table, the common causes of anemia. You can see the sickle cell is a autosomal recessive inheritance. In this case, this is an autoimmune condition. Autosomal recessive. Then you have the glucose 6-phosphate dehydrogenase deficiency anemia. It's linked to X-linked recessive deficiency. This is more genetic type of anemia. Autoimmune hemolytic anemia, abnormal immune condition in which a person's immune reactive cells fail to recognize his or her own red blood cells. Iron deficiency anemia, as I previously explained, is a microcytic hypochromic. So when you see microcytic anemias, the M, the I is corresponded related to iron, microcytic. And if you have poor hemoglobin in the RBCs, therefore you're going to have poor color. That's why it's called hypochromic. Inadequate iron intake caused by iron deficiency diet, chronic alcoholism, malabsorption syndromes, partial gastrectomy. And talking about malabsorption syndromes, usually in functional medicine, when we do is to analyze why the patient is having poor malabsorption. And sometimes we find that the issue is the low hydrochloric acid present in the stomach. That acid is helping us to absorb all the nutrients, supplements, vitamins, especially the iron. So all those patients having these surgeries to reduce weight, okay, they have partial gastrectomy, and they are sometimes getting out of parietal cells. The parietal cells are the one helping us to promote the intrinsic factor, which is also help us to absorb not only the iron but also to create B12. Okay, as I mentioned here in my notes, malnutrition is the leading cause of iron deficiency anemia. Chronic stress also prevents your body from producing hydrochloric acid. Chronic stress, that's why since day one, I suggest you to start adopting a habit for stress relief. You can do yoga, meditation, because you are entering into the nursing field, which is highly stressful. Okay, your body needs hydrochloric acid to help your body digest food. When it fails to produce it sufficiently, it affects how your body digests food and the nutrients it can get from the food you consume. the nutrients could be low. So also vitamin B12 deficiency anemia due to partial gastrectomy, due to intrinsic factor issues, pernicious anemia, malabsorption syndromes. Folic acid also is another type of anemia, and B12 and folic both are considered megaloblastic, in other words, macrocytic types of anemia, okay? So aplastic anemia is a type of anemia that is caused by exposure to myelotoxic agents such as radiation, alkaline agents, which are basically your medications, sulfonamides, your antibiotics, insecticides, as I mentioned in chapter 36 or in the previous session, pesticides, your viral infection, Epstein-Barr, hepatitis B, cytomegalovirus. All these can cause anemias. The interest factor about folic acid anemia, folic acid is your B9, okay? I was thinking the other day, it's curious, right? How they prescribe you folic acid to prevent birth defects. And we know that folic acid is essential during early pregnancy to reduce the risk of neural tube defects in the developing fetus. But at the same time, the oral contraceptives causes anemia and weak your RBC production, right? So you can see how this fact affects the development or folic acid deficiency anemia. Iron deficiency anemia is the most common anemia worldwide, especially among women, older adults, and people with poor diets. Again, the diet is very important, your nutrition. It is a decreased iron supply that results from blood loss. Blood loss could be related to your menstruation. If you have fibroids, the menstruation is going to be heavy. It could be poor GI absorption of iron, as I mentioned before, due to hydrochloric acid, or maybe ulcers in the stomach, right? And inadequate diet. So all these factors we need to take into consideration. When we are having iron deficiency anemia, we need to probably start thinking about going to the gastroenterologist, do our colonoscopy, endoscopy to check for the problems in the lower GI or the upper GI. And also through the endoscopy, they will tell you if you have problems with the hydrochloric acid as well. The GYN care will check through the ultrasound, pelvic ultrasound, what is the issue if you're having a heavy bleeding during your menstrual period, right? Maybe you have too many fibroids, cysts, who knows? So all this needs to be checked before taking final decisions about the treatment. Okay, so RBCs are small, microcytic, and the patient has mild symptoms of anemia, including weakness and pallor. Other symptoms include fatigue, because of course we have low RBCs, that means low hemoglobin, that means poor oxygen. Reduced exercise tolerance and fissures at the corners of the mouth, right? We have poor healing process. Serum ferritin values are less than 10, and the normal range is between 10 and 300. And what is ferritin? Ferritin is a blood protein that contains iron. This test can be used to find out how much iron the body stores. In other words, ferritin is our saving account. It's our saving account of iron, okay? The normal range, talking about the normal range, is always, even though your blood test will tell you have a ferritin level of 15, That is, even though it's normal, it's not, that range is not recommendable. It's not what you are looking for. Try to get above 80, 90 to be comfortable, okay? Because that 15 could turn easily into less than 10. Vitamin B12 deficiency anemia is caused by conditions that fails to activate enzymes needed to move folic acid into precursor RBC for cell division and growth into functional RBCs. These precursor cells then undergo improper DNA synthesis and increase in size. That's why they are called megaloblastic, because they are big. This anemia is described as megaloblastic or microcity anemia because of the large size of the abnormal cells. Only two anemias are considered megaloblastic or microcytic. This is the second time I am repeating it. Okay, and that's good to know. Only folic acid and B12. And of course, they are going to be hyperchromic. Okay, no hypo, because if they are big, they have more hemoglobin, more color. Anemia. Okay. Signs and symptoms. Key feature: patient does not tolerate color temperatures. And here, before we can state that this is iron deficiency anemia, we have to check our levels of thyroid, because patients with hypothyroidism also, they are having problems with tolerating cooler temperatures or cold weather. Cardiovascular signs and symptoms: continue rapid heartbeat that increase after meals and with activity, especially because you need to understand why this is happening, not just learning or memorizing the facts. If the patient is having low oxygen because he's having low hemoglobin and because he's having low RBCs, that oxygen is going to be minimum to develop activities of daily living, like eating or walking. So this continuous rapid heartbeat is because the patient is getting tired after just sitting on the table and getting their food. Respiratory signs and symptoms: breathless on exertion, as I told you before, is because due to lack of oxygen in the RBCs. Neurologic signs and symptoms: fatigue. And of course, they need to rest. They need to sleep for prolonged periods of time. Causes of B12, also known as cobalamin deficiency, include vegan diets or other diets lacking proteins. And in this sense, we have to mention our patients that are vegan, especially our patients from India, right? They have a vegan vegetarian diet, so we need to think about them. Or maybe there are patients that are having financial issues. They are not able to buy good protein, so they are only getting vegetables and not the right amount. They are only eating carbohydrates, and or maybe they have bad information about how much, if they want to become vegetarian, what is the balance, what is the proportion in order to keep the B12 in good standing. A small bowel resection, as I mentioned before, all these patients that are having these surgeries in order to lose weight, they are in risk. Chronic diarrhea, diverticula, which are little pouches in the small intestine, tapeworm on overgrowth of intestinal bacteria. So it's question of getting an analysis of if you're having deficiency in your probiotics, in your prebiotics. How is your flora? How is your microorganisms in your gastrointestinal tract? Anemia resulting from failure to absorb vitamin B12. Pernicious anemia is caused by a deficiency of intrinsic factor, which we mentioned, of course, a substance normally secreted by the gastric mucosa, which is needed for intestinal absorption of B12. Pernicious anemia is a type of autoimmune disorder, and this is good to know. treatment must be for the rest of your life if you're having a B12 or pernicious anemia. It's autoimmune disorder. Vitamin B12 deficiency anemia may be mild or severe and usually develops slowly. Specific symptoms include pallor and jaundice, glossitis, a smooth, beefy red tongue. Um, and that's another good to know because in iron deficiency anemia, multiple shades of red and swell slightly in size is one of the characteristics of your tongue. That's the difference between iron deficiency anemia. You are going to see in the tongue multiple shades of red and swell slightly in size. However, in B12, the tongue is going to be beefy red and smooth. Make that difference. Don't get confused if when you're assessing the mouth and the tongue of a patient, if you see shades of red, then that is iron deficiency anemia. When it's a smooth beefy red, is B12. Okay, patients may also have paresthesias and abnormal nerve sensation in the feet and hands and poor balance because B12 helps maintain nerve function. Okay, and that's good to know too. B12 is always presenting with nerve function problems or issues versus folic acid. Folic acid, even though B12, folic acid are both megaloblastic or microcytic, B12 is going to present with nervous function, the numbness, the paresthesias, maybe problems with behavior, anxiety, changes in the mood. Folic acid is different. It's going to present with multiple symptoms similar to B12, but none of them is going to be nerve related. However, paresthesias do not occur because folic acid deficiency alone does not affect nervous function. This disease develops slowly. Yeah. So we clarified that. Here you can see the glossitis, a smooth tongue as a result of B12 deficiency anemia. Other patients often have poor diets or chewing difficulties, and thus are at risk for anemias that result from deficiency. Ask about family history of B12 deficiency anemia often occurs in patients 50 to 80 years of age. So B12 could be related to, I am going to refresh again, it's an autoimmune disorder, but sometimes it could be related to lack of good protein intake. So in these patients, 50 to 80 years, you need to assess who are they living with, what is their financial situation, who is cooking, who is preparing the meal for them. Aplastic anemia is a deficiency of circulating red blood cells because of impaired cellular regulation of the bone marrow, which then fails to produce the cells. It is caused by an injury to immune precursor cell for RBCs. Although aplastic anemia sometimes occurs alone, it usually occurs with leukopenia, a reduction in white blood cells, and thrombocytopenia, a reduction in the number of circulating platelets from reduced platelet production, a condition known as pancytopenia. Disease onset may be slow or rapid. So pancytopenia is a reduction in the three little soldiers of the blood, your RBCs, your WBCs, and your platelets. Okay? Then we have the glucose 6-phosphate dehydrogenase deficiency. Anemia is a genetic problem in which there is a deficiency of the enzyme G6PD. The disease is inherited as an X-linked recessive disorder. So far we have B12 autoimmune, G6 is genetic. Okay, just to make a brief recap. Immunohemolytic anemia, also referred as an autoimmune hemolytic anemia, is caused by immunity problems that, for unknown reasons, allow a person to form antibodies that attack and destroy his or her own RBCs membranes, which is called lysis. This process is called lysis. So we have an NCLEX question. Which type of anemia does the nurse ask the client about the presence of a disorder in other family members? So select all that apply. Sickle cell anemia. We have a history, right? We have folic acid is not there. Glucose 6-phosphate dehydrogenase anemia also, and pernicious anemia. Okay, so when we consider family history, those three anemias are going to be present. Okay, vitamin B12 deficiency anemia. Professor, why vitamin B12 is not in the list? Because that is the consequence of pernicious anemia. It's almost the same, but the umbrella is pernicious anemia. Okay, let's continue. Iron deficiency anemia management involves increasing the oral intake of iron from food sources, red meat, organ meat. Professor, what organ meat? It's liver. Liver is a good choice. If you are able to find organic liver, you are blessed. Okay, it's kind of difficult and it's kind of expensive, but it's one of the best sources. Egg yolks, kidney beans, leafy green vegetables, and raisins. If iron losses are mild, oral iron supplements are started with the hemoglobin level returns to normal until hemoglobin returns to normal. If the supplement causes GI distress, they can be taken with meals. Having said that, the optimal way to take iron supplements is in between meals on an empty stomach and with vitamin C. Professor, why vitamin C? Because we are looking for acidic environment, right? If we are having deficiency in hydrochloric acid, then the vitamin C is going to help us to balance that deficiency. Now, if the patient is taking, this is good to know, and it's not in the book, that's why I always go to the book to assess what information you are getting and what information you are not getting. And I compare whatever I see in the book with my source, my NCLEX source, because I am trying to prepare you for the NCLEX exam. I'm trying to provide you with the information that is often tested in the exam. So that way you are studying for these exams from now. You are not wasting your time during the semester learning facts that are not going to be in the NCLEX. Okay, that's good to know also. However, okay, let me say this. If you take liquid iron, you have to take the iron with a straw because the iron, the liquid form, is going to stain your teeth. And that's not a fact that is stated in this book. Okay, I want to present this to you. It's going to come, you're going to see it in the NCLEX. Okay, let me see. When iron deficiency anemia is severe, iron solutions like irodextran, ferromoxitol can be given parentally. Vitamin B12 deficiency anemia is managed by teaching the patient to increase his or her intake of food with rich in B12, animal proteins, fish, eggs, nuts, dairy products, dry beans, citrus, and leafy green vegetables. Having said that, you are going to see in NCLEX a lot of questions, a lot of questions that is going to assess if you are mastering your nutritional sources, what nutritional sources you need for B12 anemia, what nutritional sources you need for iron deficiency anemia. Make sure you review that. Okay, make sure you review that and you master these concepts. Ferumoxytol has a black box warning for an increased risk for life-threatening anaphylaxis that can occur during or within 5 minutes after receiving the infusions. Stay with the patient during infusion and for 10 to 15 minutes after the infusion is complete. For all of you who are going to work in hematologic clinics and the doctor is prescribing ferumoxytol, please be aware about this black box warning, because you are the nurse. You are the final step between the prescription of the doctor and the patient. If you see and you notice there is a prescription with black box warning, you as a final step are able to stop this medication. Always you have to check your side effects and compare with the patient condition, okay? Patients who have pernicious anemia are given vitamin B12 injections weekly at first and then monthly for the rest of their lives. We know B12 is an autoimmune condition. Or a B12 preparation and nasal spray for sublingual cobalamin preparation may be used to maintain vitamin levels after the patient's deficiency has first been corrected by the traditional injection method. And that's good to know. Folic acid deficiency anemia is best managed by identifying adults at risk and preventing the deficiency. Who are the adults at risk? The elderly population, debilitated patients with alcoholism. Okay, do you remember I told you at the beginning of this session I was going to talk about nutrition and about the bad habits? So there you go. You have to prevent alcoholism, smoking, drugs, and get better nutrition. Malnourished patient, again, the same. A diet rich in foods containing folic acid and vitamin B12 prevents deficiency. You notice now that not only the pregnant women and the woman in the period where they can be pregnant needs folic acid. They are not the only ones. Also in the adult ages we need folic acid. This anemia is managed with scheduled folic acid replacement therapy. Aplastic anemia for transit or drug-induced aplastic anemia. Short-term management may include blood transfusion along with discontinuing the responsible drug. Blood transfusions are used when the anemia causes debility or when bleeding is life-threatening because of low platelet counts. This therapy is discontinued as soon as the bone marrow begins to produce RBC if the problem is transient. How are you going to know the RBCs and everything is going back to normal? Check your blood work. That's why always I will suggest you to be familiarized with the normal ranges, your CBCs, your complete blood count, your RBC, WBCs, your platelets. Your nurses love to monitor when we are talking about WBCs, your neutrophils, your lymphocytes, your monocytes, eosinophils, and basophils. Your nurses love to monitor. Nurses stands for neutrophils. Love stands for lymphocytes. Monitor stands for monocytes. Okay. What else? Where are we? Immunosuppressive therapy like prednisone, cyclosporine have resulted in partial or complete remission when in the case of aplastic anemia, remember, because they are trying to stop the immune system to work in a bad proportion. Splenectomy may be needed for patients with an enlarged spleen that is either destroying their normal RBCs or suppressing their development. Hematopoietic stem cell transplantation with donor cells is the most successful method of treatment for aplastic anemia that does not respond to other therapies. When we talk about hematopoietic stem cell transplantation, we are talking about the three types of cells, the RBC, WBC, and platelets. However, all transplantations or the hematopoietic stem cell starts with the pluripotent cells that they need to mature and then become ready for the transplantation. The glucose 6-phosphate dehydrogenase deficiency anemia management has prevention as the most important strategy. Patients, especially men who belong to the high-risk groups, should be tested for this problem before receiving drugs that can cause the hemolytic reaction. Hydration is important during an episode of hemolysis to prevent debris and hemoglobin from collecting in the kidney tubules, which can lead to acute kidney injury. This is another good habit, to drink a lot of water, right? So proper nutrition, to stay away from bad habits, and increase hydration. No matter what the condition is. Transfusions are needed when anemia is present and kidney function is normal. Immunohemolytic anemia management depends on disease severity. Steroid therapy to suppress immunity is temporarily effective in many patients. Immunotherapy with rituximab, a monoclonal antibody, splenectomy, and more intense immunosuppressive therapy with chemotherapy are used if steroid therapy fails. Polycythemia vera is one of the chronic myeloproliferative neoplasm, myelo. So we need to see and we need to remember the graphic from the previous chapter. We have the pluripotent stem cells that are coming from the embryo, and then it branches into two pathways, the myelo that is coming from the marrow, and the lympho that is coming from the lymphatic system, right? So in the lympho, we have the three branches, the no bomb threats. That's the acronym. No bomb threats means no stands for your natural killer. Bomb stands for your B lymphocytic cells. And T threats stands for your T lymphocytes. No bomb threats. That's the one from the lympho. And the other one, the myelo, is having your erythrocytes, which are the precursors of the RBCs, your platelets, and then you have the ones that are related to the WBCs, your macrophages, eosinophils, basophils, okay? So in this case, when we are talking polycythemia vera, chronic myeloproliferative neoplasm, so meaning it's coming from the marrow side, in which there is a loss of cellular regulation with excessive expansion of specific groups of abnormal cells with decreased function, in which the number of RBCs of the blood is greater than normal. The blood of a patient with polycythemia is hyperviscous, thicker than normal blood. Hyperviscous, and this fact is good to know because clotting could develop pulmonary embolism or deep vein thrombosis because the blood is very viscous, right? Pulmonary embolism or deep vein thrombosis. If you come across two patients, my future ER nurses, you admit a patient with pulmonary embolism and the other one is having deep vein thrombosis. Which patient are you going to treat first? Critical thinking nurses? Yes, good answer. You're going to treat first your pulmonary embolism patient because remember your ABC, airway, breathing, circulation. Airway is the first thing you need to take care of. Okay, let's continue. The blood hemoglobin levels in polycythemia vera are sustained at greater than 18 GDL in men or greater than 16.5 in women. It's usually a cancer of the RBCs with three major hallmarks: a massive production of RBCs, excessive leukocyte production, and excessive production of platelets. Polycythemia vera. Poly, multiple. Okay? Polycythemia vera. Basically RBCs, excessive WBCs, excessive platelets. Polycythemia vera have a mutation of the GAK2 kinase gene in the affected cells. This mutation causes a loss of regular regulation over blood cells. So if you want to be more technical, you can remember pancytopenia. Pancytopenia is the reduction of the three soldiers. Polycythemia vera is the excessive production of the three soldiers. Okay, that's a good way to remember. The patient facial skin and mucous membrane have a dark purple or cyanotic flash plethoric appearance with distended veins. Where are you going to assess your distended veins? Probably on the side of the neck, right? Vascular stasis causes thrombosis because there is a high risk of clotting due to high production of platelets within the smaller vessels, occluding them, which interferes with perfusion and leads to tissue hypoxia, anoxia, and later infarction and necrosis. Tissue most at risk are the heart, the spleen, the kidneys, although damage can occur in any organ. Lifespans are shorter in patients that are having this disease. Rapid turnover of circulating blood cells, and so you have high production and shorter lifespan of the cells, right? Because they don't get to the maturing point. This rapid turnover increases cell debris released when the cells died in the blood, which further thicken it. So you have the debris of the cells that are living a short period, and you have the bone marrow producing a lot of all these three soldiers, and they don't get to the mature state. The debris includes uric acid and potassium, which cause the symptoms of gout and hyperkalemia, of course, elevated serum potassium levels. Even though the number of RBCs is greatly increased, their oxygen carrying capacity is reduced. Yes, because they are not mature. And patients have poor gas exchange with severe hypoxia. You have a lot of RBCs, probably you're going to see an elevated number of reticulocytes. We know those are the baby RBCs. But since they are not getting to the mature point, remember that the RBCs are living for 120 days. So they are not full mature. They are not having full capacity to retain the oxygen the body needs. Okay? Bleeding problems are common because of platelet impairment with poor clotting. Okay. Polycythemia vera, drink at least 3 liters of liquids each day to get rid of all debris and in order to do not block the kidneys. These are points that I have selected. That doesn't mean that these are the most important, no. Just paying more attention to this. Wear gloves when outdoors in temperatures lower than 50, right? Because you can get sick since the WBCs are not full mature. Take anticoagulants as prescribed. Yes, because of the high number of platelets. Elevate your feet whenever you are seated because you want to avoid thrombus. Use a soft bristle toothbrush to brush your teeth. Of course, your platelets are not having good clotting factors. If you are a smoker, strongly consider smoking cessation. Intervention, if left untreated, few people with polycythemia vera live longer than 2 years. After diagnosis, when managed by repeated phlebotomy and apheresis, 2 to 5 times per week. Professor, what is apheresis? So these patients that are having excessive RBCs, they go for the phlebotomy, they are going to remove certain amount of RBCs. This blood is going to be filtered and then is going to be infused back into the patient, okay? It's here. Apheresis is the withdrawal of whole blood and removal of some of the patient's blood contents. In this case, RBC, the plasma is then reinfused back into the patient. Increasing hydration and promoting venous return help prevent clot formation. Drug therapy for polycythemia vera includes anticoagulants. So aspirin may use to decrease clotting, but increases the risk for GI bleeding. Okay, So we're going to stop here, and then we're going to come back with more of this chapter. And yes, this is a long chapter, and I would say it's one of the most important chapters in the whole semester. Be prepared. This semester is full in content about cancer. We're going to talk a lot about breast cancer, all the GYN cancers, and also the cancers related to men. Okay. I would say that all the gastrointestinal concept that we are going to learn, and all the cancers, and including this particular lecture about hematological and oncological, are the ones that are not only the most important and heavy in this semester, but also those are important topics in healthcare. Therefore, the content that you're going to see in NCLEX related to these three topics that I mentioned, GYN, men-related cancers, the gastrointestinal, and anemias, and all these hematological, are going to be heavy in NCLEX. Okay, so I want to provide as more detail as you need to know to be prepared for this important test. Okay, when we come back, we will check leukemia, multiple myeloma, thrombocytopenia purpura, and lymphomas. Okay, take a break.